Hello. Okay, welcome everyone. My name is Ben Lee. I'm a volunteer with the Bay Area Association of Kidney Patients. And I'm very happy to see such a great turnout for this event. He is a member of the Chabot Nephrology Medical Group right here in Oakland and has been so since 2012. Dr. Gilani received his medical degree from the University of Texas, where he also completed his Bachelor of Science in Biochemistry. He served as a nephrology fellow at Emory University in Atlanta, Georgia, where he was certified in renal ultrasonography by the American Society of Diagnostics and Interventional Nephrology, and where he has also performed research in many areas, including dialysis access for undocumented populations, genetic variations in hypertension, and polycystic kidney disease. Dr. Gilani served his residency at Baylor College of Medicine in Houston. And Dr. Gilani is also active in research in areas such as clinical decision-making, hypertension, and transplants, various approaches to glomerular diseases, disorders of the thyroid and the pituitary, and many other conditions like those above that are related to kidney disease. And very admirably, very deep in your CV is the fact that I noticed that you also personally assisted the disaster relief of Haiti. It was way deep in your CV, and I thought that was fabulous. So, we're very fortunate to have this kind and public-minded doctor to volunteer your Sundays with us. So, everybody, please welcome Dr. Gilani.
Thank you so much. I'm going to try not to use a microphone. So, am I speaking loud enough for everybody?
Yes.
Okay, great. Where's the clicker?
The clicker is your little finger.
Oh,
It's
okay.
that. I don't have a clicker.
Okay,
Unfortunately.
Well, okay. Hi, everyone. I'm Hussain Gilani. Nice to meet all of you. I really want to express immense amounts of gratitude to the people at the BAAKP. It is a wonderful organization. It does a lot of good. I have a lot of patients that are active participants in it, and I know that it has provided immeasurable amounts of support for them, and it makes my job a lot easier when it comes to talking to my patients and educating them about kidney disease. So thank you for the wonderful introduction. Who am I? Like I said, I went to the University of Texas. I'm from the South. I like to say I immigrated from Texas to California because these places are so different. What really motivated me and what really got me into studying kidney disease was very early on in my career in medical school. There's a million different reasons why, but the biggest reason is I feel like kidney disease is just underrepresented. There's not enough attention paid by the general public to kidney disease. There's a lot of room for advocacy. I get a lot of satisfaction. The most satisfaction out of my day is being able to spend 30 minutes to an hour just teaching patients about what's going on with their kidneys and making a difference in what decisions they make moving forward. And you can do that in other fields, but I feel like with kidney disease you can do it more. You have more of an impact there. So that's why I went into nephrology in the first place. There's a million other reasons too, but that's the one that sticks with me the most. So when I was approaching this lecture, it's a very broad topic, and it's very difficult to kind of really go over everything in immense detail. So what I'm going to try to do is focus on the pearls that I want my patients and the general kidney population and family members to understand. It would be impossible to go over everything, but I think the things that I'm going to try to touch upon are the things that I feel like a doctor would want their patients or their family members to know. So first and foremost, what are kidneys? Okay, so most people are born with two kidneys. They are about the size of your fist. They kind of sit here near your flank, and what they do is they clean up your blood. They produce urine. So your kidneys have a functional component called a nephron. You have millions of them, about 1 million in each kidney. And so basically blood goes into the kidney. It is dispersed and is filtered in this little area called the glomerulus. Okay, so there won't be a quiz afterwards, so you don't need to memorize these names. But the glomerulus is that very vital portion of the kidney that does its job. It filters the blood, and that's where urine is initially made. So then what happens is dirty blood goes into the kidney, clean blood goes out of the kidney, and urine flows out into the bladder from the kidney itself. The kidneys do a million other things too, not just clean blood. They regulate your bone strength, they regulate your anemia levels, they do a lot of other things too. A lot of hormones are secreted from your kidneys, the blood pressure is managed through your kidneys. And when you have kidney disease, a lot of other things happen too, particularly with heart disease and strokes and things like that. What causes kidney disease? Well, in the United States, the most common cause of kidney disease is diabetes. Almost half of patients that have kidney disease have it from diabetes. And then a quarter have it from high blood pressure. Outside of that, but that's just the U.S. population as a whole. In our population here in Oakland, where we have predominantly African Americans, there's certain diseases that affect African Americans more, like one called focal segmental glomerulosclerosis. So that's probably the most common cause of that. Not a quiz afterwards, so you don't have to know that name. But usually it's something that either affects the blood vessels or it affects the filters. Okay, and so our approach when we have a patient that shows up with kidney disease is to try to prevent the end stage of that disease, try to prevent dialysis, try to prevent the need to get a kidney transplant. And the earlier we see you, the easier it is to provide extra time with your normal kidneys or without needing dialysis. So this is just a schematic to drive that point home. So the earlier a kidney specialist sees you, and the earlier we're able to implement the things that we want to do to help prevent your kidneys from failing, the more time you have. So like for instance, this person, the natural progression of their disease is their kidneys have failed after 4 years, after 7 years. But if we start intervening at year 4, then their kidneys are failed at 9 years, and if we even start even earlier, 11 years. So this is just a demonstration of what that means, and everyone is different. But the earlier we get to see you, the better chance we have at keeping you off of dialysis, keeping your kidneys, keeping your native kidneys to do the job that they're designed to do. So how do we do that? Well, the first step is we have to figure out what is the cause of your kidney disease. What is doing this? What is causing this process? So it's actually a pretty simple evaluation when you break it down. The first step is let's get an ultrasound. Let's take a look at what your kidneys, the structure of your kidneys are. We can tell a lot from an ultrasound. First and foremost, is there a structural component that's causing this problem? Like, is there a problem with the plumbing? Or is there a problem with cysts? Or is there a problem with something like that? And some of those are easy to fix, others are not. The second thing that the ultrasound does is it gives us a clue as to how damaged the kidneys are. So if you have smaller kidneys than normal, and if they are more dense than normal, then we know that your kidney disease has been going on for quite some time, and there isn't much we can do to reverse it. And we should focus our efforts at preserving what we have left. If the kidney is normal size and is not dense with scar tissue, then maybe there's more hope to do something to reverse whatever kidney disease you do have. The second thing that we do, outside of monitoring your clearance and whatnot, is to categorize whether or not you're a patient that spills your protein into your urine or does not spill protein in your urine, and that's a very, very important distinction. If you do not spill protein into your urine, then our evaluation of trying to figure out what is the cause of your kidney disease is mostly done. And our efforts are focused primarily on controlling blood pressure and slowing down the progression of any disease. If you do have protein leaking into your urine, then then the next step is to figure out, well, what's causing that? It's probably a problem with those millions of filters that you have, a disruption of those filters. Those are the things that are supposed to keep protein in the bloodstream and not into the urine. And those are the focus of our diagnosis. Sometimes we have to do a kidney biopsy to figure out exactly what it is. Sometimes we can just tell based on, well, if you've had diabetes for many years or if you have something else that's going on, we can tell by those or by blood work. But for the most part, that distinction of protein is very, very important. And it's a number that you should know as a patient. Am I putting out a lot of protein in my urine or am I putting out very little protein in my urine? That is very important to know when it comes to your risk for progressing further. So what are the important things that you should do as a kidney patient? Well, first and foremost, attend seminars like this, educate yourself, read what's available to you, information that's available. There's certain websites that I'll share that are very useful. In our office, we have a library of books that you can check out and read as well. There's a lot of good information out there. There's some bad information out there too, so you want to run whatever it is that you're reading by your specialist or by someone in the healthcare sphere so you have an idea of what you're reading is helpful or not. The second, and this is extremely important, is blood pressure control. This is a number that I want everyone to memorize, 130/80. This is what your blood pressure should average. Not necessarily be, it should average. Your blood pressure, it's meant to go up and down throughout the day based on what you're doing and what kind of stuff. But it should be averaging around there. That's going to keep you at the least amount of risk. I ask all my patients to have blood pressure cuffs or machines at home because, in my opinion, when you come to my office, you're there for 15 minutes or, if it's Iris, an hour, hour and a half. But you're there for a very short amount of time with it. And that's not entirely representative of what you're doing every day in life, at home, at work, what have you. So that one blood pressure reading I'm getting, if I'm trying to guess what your blood pressure is throughout the rest of the time, I'm not going to do that great of a job. I will make adjustments based off of that, but if you have a blood pressure cuff at home and you have an idea of what you're averaging, then that's going to make my job easier, but it's going to make it a lot easier for you to be able to have a better control of your blood pressure. The next thing that's very important is just to avoid things that can harm your kidneys. So when you think about it, your kidneys are cleaning up, 100 milliliters a minute of blood, or, if you have some kidney disease, maybe half of that or a little less than that. But that's a lot of blood that is passing through those filters every minute of every day that you're alive. So anything that you ingest that is a medication or an herbal supplement or has any contaminants, things like that, those can tend to accumulate and cause damage within the kidneys. So any medication that you're starting or any supplement or herb that you're thinking about doing, you want to educate yourself on before you take it because you don't want to harm your kidneys from it. Next, healthy eating habits, exercise. Claire is going to do a wonderful job of explaining what you should and shouldn't be eating and just the nuances of a kidney diet. Exercise is something that we don't talk enough about, but it's something that we should all be doing as well. That has been shown to reduce the progression of your kidney disease as well. And I'll go into that in a little bit of detail later. And you should know what your kidney numbers are. Know what your risk level is. And that's something that your doctor can help explain to you and you can learn and follow on your own as well. And lastly, but also very important, is planning ahead. I can't count the number of times I've had a patient come into my office and say, "Doctor, I never want to be on dialysis."
Okay.
So, yeah, exactly. "Doctor, I never want to be on dialysis." And I'm saying, okay, that's great, but if it was between life and death and you needed dialysis to live, then what would you do? Oh, then I'll do dialysis. So it's an avenue to kind of avoid the question to think, oh, I never want it, but if it becomes life and death, I will. And it's important for us to have you plan ahead because there's certain things that we need to do 6 months in advance or what have you, so that you start dialysis safely if you need it. And lastly, transplant is also an important thing to get started before you need dialysis, because those people that get kidney transplants before they start dialysis actually do better. Those transplants actually work better. So anticipating these problems, seeing a kidney specialist early will help prolong your time before your kidneys fail, but also, you may not need dialysis if you can anticipate when to send someone for transplant. So first step, educate yourself. So there's 3 websites I want to highlight. So National Kidney Foundation, I've pulled a lot of my slides off their website because they do a very good job of educating patients. The BAAKP website does a very wonderful job, and local events, focus groups, support groups. These things are things that are immensely helpful because I can't anticipate everything that's going on, but if you meet with someone that has gone through what you have gone through before, they can provide a level of support that is beyond anything I can do, and I appreciate a lot of my patients that do that for other people because it's really helpful, and this organization as a whole as well. And then the Chabot Nephrology website, we have a patient education tab on our website that has a lot of useful links that you can learn about, and these are vetted websites that help you that we know have good information. And lastly, there are a lot of good books out there too that we can provide through our office. All right, so speaking of blood pressure, like I said before, 130/80, that's an average. So there are certain medicines that help more so than others. They're called ACE inhibitors or ARBs, and a lot of you have probably been on them or are on them currently. The ACE inhibitors, they always end in that pril, like enalapril, lisinopril. ARBs, they always end in Artin, losartan, valsartan, olmesartan. So what do they do that's so much more special than regular blood pressure? So first and foremost, they help with blood pressure. They help with blood pressure in a couple of different ways. But second of all, they act within the kidney itself on the nephron. So what they do is they dilate the vessel that goes into the filters. They constrict the vessel that goes into the filters. Then they dilate the vessel that leaves the filters. What that does is it reduces the blood pressure within the filters themselves. So your kidneys actually, they don't work as hard. So a lot of patients, what we do is when we put them on these medications, they notice that their kidney function is worse. They say, oh my gosh, my kidney function is worse. That's actually what we want to some extent. We want your kidneys to not work as hard because then they'll last longer on these medicines. But these medicines, they can cause some problems, and one of them is with potassium. These medicines raise your potassium levels. So that's one of the reasons why, even a little bit earlier than when you're on dialysis, we want you to be on a lower potassium diet. If it applies to you, we want you on a lower potassium diet because we want you on this medicine as long as possible. These medicines will keep you off of dialysis. By the studies, they'll keep you off of dialysis longer. One other point when it comes to blood pressure, and everyone has an individualized thing, but I did research at Emory looking at blood pressure at night when you're sleeping, and it's protective if your blood pressure lowers. It's called dipping. And so one of the ways that you can mimic that effect is by taking at least one of your blood pressure pills at night. It doesn't matter as much. It shouldn't be your water pills because then you're going to be up all night going to the bathroom, not sleeping. But it's helpful to have at least one blood pressure pill at night. That's going to protect your heart. It'll protect your brain. So I think that's important. Next, when it comes to blood pressure, is avoiding salt. Salt is a very difficult thing to avoid, especially in our society, but it can be done. Claire is going to teach you how to do it. But you should aim for less than 2 grams a day, and exercise is also helpful for blood pressure. And when I talk about exercise, there's a lot of different things they can do for exercise. There's a lot of different studies out there looking at different forms of exercise. One study I just heard on the radio was talking about how they got people, so they had an alarm on their watch, and for 2 minutes every hour. They just got up and walked around, not necessarily even doing anything strenuous. They just did 2 minutes every hour, so that adds up to about 30 minutes a day of just making sure you're getting up from your desk or whatever it is you're doing. And those patients had better obesity profiles, better blood pressure profiles. So something as simple as that, in addition to what you're already doing, can be helpful. But when I talk about exercise, I also think about focusing on, your biggest bang for your buck. So cardiovascular exercise, that's helpful. It really, really is. But you also want to do things that are weight-bearing, especially for the kidney population. Weight-bearing exercises, resistance exercising. You don't have to be a bodybuilder. You don't have, but like focusing on things that focus on the biggest muscles in your body, your legs, so your quads, your hamstrings, your glutes, those things like squats, lunges, something along those lines that builds muscle mass will have a lot of benefits. It shows that your kidney function will deteriorate at a slower rate, so your kidneys will last longer. It shows that building muscle mass is the more efficient way to lose fat. Building muscle mass helps with insulin resistance, because the more muscles you have, the more insulin receptors you have. And it helps from the standpoint of bone strength, which is a big, big issue with kidney patients. So preventing osteoporosis. Very important to do weight-bearing exercises within the mix.
Is that walking?
So walking is more like a cardio, but trying to mix in something, even like those resistance bands, things along those lines, just try to mix it in. Don't walk less, just add this into your regimen. Okay, so when it comes to things to avoid, NSAIDs, non-steroidal anti-inflammatory drugs, NSAIDs, very important. And I think 90% of the time when you meet a kidney doctor, they go through the list. Ibuprofen, also known as Motrin, Advil, Aleve, all these things, avoid. But be aware. I can't tell you the number of times I've had a kidney patient go to the emergency room for a gout or something, and an ER physician doesn't check their blood work, because it's something you don't need to check blood work for. Out on an NSAID that is potentially dangerous for their kidneys. So you need to be your advocate when it comes to getting pain medications in this sphere. Don't count on the doctor knowing that you have kidney disease. Tell the doctor you have kidney disease. When it comes to the renal diet, Claire's going to go over this in detail. Basically, limit sodium, potassium, phosphorus. Protein is a very tricky thing. The exact amount of protein that you require may be more than what you're already eating. So then when you see a doctor and says, hey, I need you to restrict protein, that's going to help keep your kidneys alive longer, you may already be doing that. So it's best to kind of do the math and estimate how much protein you really need. So if you're a CKD patient, pre-dialysis patient, the goal is about 3 to 4 ounces of meat. The ballpark is half the size of the palm of your hand. But it's better to just do the math and figure it out for yourself based on your size. And then when you're on hemodialysis and peritoneal dialysis, there's differences there too. Hemodialysis patients, the filter itself removes some potassium from your blood. Peritoneal dialysis, you lose a little bit, sorry, not potassium, protein. Peritoneal dialysis, you lose actually a lot more protein through that system. So we're actually trying to convince our patients to find ways to get more protein in their diet in that situation. So be aware of that. When it comes to a renal diet, the one thing I really want to stress is that you also want to address the cause of your kidney disease with your renal diet. As Viveka was pointing out earlier, she lost 120, that's amazing, actually, really, really amazing. 120 pounds. 100 pounds, sorry, 100 pounds, my math is a little bit off. That's amazing.
Take the 20 though.
I'll give it to you. All right, no, but focusing on those things. So, we as Americans, we're not really eating real food anymore. We're eating this processed junk that doesn't really, honestly, it doesn't even taste good if you take the sugar and salt out of it. It is not real food. So if you're going to McDonald's, or if you're going to Burger King, or if you're buying TV dinners or things like that.
Lunch meat, hot links, hot dogs.
Exactly. If you're doing all those things, a lot of the reason that tastes good, it's a chemical trick onto your brain. They're adding sugar into that. It's causing you to be addicted to these substances, and you got to get off of it.
Yes.
You just got to. We don't eat enough fiber as a society. Eating more fruits and vegetables will get you there. And when we talk about the kidney diet, it gets in the way of some healthy eating in some circumstances. Limiting the potassium that you're supposed to eat will get people off of some fruits and some vegetables. There are a lot of alternatives, but you also have to put it in context. If you're like a CKD stage 3, if you only have mild kidney disease, you're probably not having that much trouble with your potassium. So by all means, have at it. Just talk to your kidney doctor and make sure you're not in that high risk area when it comes to potassium. It's important to individualize your diet. And so, we have nutritionists. So if you're a dialysis patient, you're lucky in the sense that you have someone like Claire, or you have a nutritionist that you meet with about once a month. If you're not on dialysis, it's a little bit difficult, but we can refer you to nutritionists that you can meet with and learn a little bit more. But that's also the point of self-education as well. Really, the kidney diet is very important, but focusing on other aspects of that. Also, learn how to read the labels. Yes?
Yes. Yeah, I was saying 2,000 milligrams of salt and 1,000 milligrams of phosphorus.
Mm-hmm.
What are you saying about that?
Claire is going to go through that in
We're not
immense
supposed to be
detail.
eating that.
What I say about that is this. I had a patient
That's bad.
in a hypertensive clinic. I was doing a research study on him. And so you can estimate how much sodium someone eats by collecting all their urine for a 24-hour period.
You're saying that's bad.
Less than 2,000. You want to do less than 2,000.
And less than 1,000 of phosphorus?
Yeah, 1,000 or 1,500. That's the ballpark, especially if you're on dialysis. Yeah, I had a patient who we did a study on calcium excretion in the kidneys, but we basically, part of the study was seeing how much sodium this guy was consuming, and he was supposed to be on a 2-gram, 2,000 milligram sodium diet. We counseled him and said, okay, these are the things you should eat, and we're going to measure your urine for some other reason, but we're also going to know how much sodium you actually ate that day. He came back to me, and he was at 22 grams. 11 times the amount he was supposed to be eating. It's like, what were you doing? How did this happen? He said, well, I'm kind of poor. I only eat at work, and I work at Church's Chicken, and I work at McDonald's. So I sat down with him for about an hour. We went through the McDonald's menu, the menu of McDonald's, and we found the things on the McDonald's menu that he could get to 2 grams of sodium. And we said, okay, this is only what you're allowed to eat. It's only for one day. You can do it. Just do this. So okay, I'll do it. And he's a very motivated guy. He comes back to me. It went down to 14 grams. Okay, so even when you're trying to do your best, if you're eating this outside processed junk, then you're not going to be doing what you should be doing. Okay. So read the labels. Learn to read the labels. The labels can be a little misleading, but learn to read them. It's important. Pay attention to serving size and servings per container. Know the amount that you should be eating. So if you consume this whole, whatever this is, I think it was soup. If you just do the whole can of soup, then that's half of the amount of sodium that you're supposed to have for that entire day. So just pay attention to that. Also, just an interesting point, notice how everything has percentages except sugars. For some reason, we don't say how much sugar you're allowed to eat as a society. But I mean, half the patients are on dialysis or on it, or have kidney diseases from diabetes that we're not telling you how much sugar you should or should not be eating. So you pay attention to that yourself. It's very important. Most of the sodium comes from processed food and restaurants. Some things would surprise you. Bread, in particular, a huge source of sodium. Everyone's addicted. All my patients are addicted to bread, and we shouldn't be. But just have to cut it out, not just from the kidney standpoint, but also from a diabetes standpoint as well, and a hypertension standpoint. And potassium, we've kind of gone over that. I'm not going to leave this up for too long because Claire's going to go over it, but also I don't want anyone to cheat on the quiz. Phosphorus is very important. Phosphorus is in all the foods that we eat. It's a building block of energy for life. but phosphorus is also very dangerous for a kidney patient. And you don't need to memorize this. The point of this slide is basically 95% of all the phosphorus in your body is in your bone. It's not in your bloodstream, it's in your bone. When you do dialysis, we only remove the phosphorus from your bloodstream. So we're not able to remove a lot of phosphorus on dialysis, regardless of what type of dialysis you do. Okay? So it is impossible to get enough calories to eat as a kidney patient without getting too much phosphorus. Okay? So that's why those medications like the phosphorus binders exist. It mixes with the food in your stomach. You poop out the phosphorus instead of absorb it. The phosphorus that's left in your body, that's extra, where does it go? It doesn't go to your bones, really. It goes into the blood vessels of your heart. It causes heart attacks. It causes strokes. So it's really important. You know, it's very easy to kind of blow off the phosphorus because it's something that's really hard to do. You know, we're telling you, eat more protein if you're a dialysis patient. But we want you to limit your phosphorus. It's very difficult. But long-term wise, there's a very strong association with that phosphorus and the things that are going to end your life, you know, heart attacks and strokes. So pay very good attention to that, okay? And where does all this phosphorus come from? So phosphorus is in all foods. Some foods have more of it than others. There's a difference, there's a distinction. There's organic phosphorus and inorganic phosphorus, okay? So organic phosphorus, it means it comes from like a plant or an animal. Inorganic phosphorus is, it was made in a lab and it was made as a preservative probably for the food that you're eating. If you're eating, if your source of phosphorus is from a plant, your gut can only absorb about 1/3 of that phosphorus, okay? So plant sources of phosphorus, a little bit better than animal sources. Animal sources of phosphorus, 50%. So 50% of the phosphorus in what you're eating is going to be absorbed into your bloodstream. If it's an inorganic phosphorus, so a phosphorus made in a lab used as a preservative, then 100% of that is absorbed. You absorb it very readily. And this is just to demonstrate what that phosphorus does, okay? So this is a Happy Meal. This is what you feed your children at McDonald's, okay? So this is day 1. This is day 180. It has not changed at all. What's that?
Not one bit.
Yeah, exactly. So this isn't real food. I mean, if you had an apple next to it, what would that look like after 180 days, right? Yeah. So fast foods in particular, processed foods in particular, try to avoid, they're riddled with salt, they're riddled with sugar, but they're also riddled with phosphorus.
Can I ask a question?
Yes.
You said it hasn't changed at all. I got lost with that.
This hamburger here is 180 days old. This is the same hamburger.
Oh, it really
Day
is
one.
180 days.
This is 180 days old. This has just been sitting there in the open air. Because I was going through this with a patient on Friday, I think. Because I was like, yeah, I think I saw this somewhere, and we Googled it together. And and so I was like, I was showing her, well, yeah, this, because it was showing the images of it at 20 days. Like, this is 20 days. And then I kept scrolling down, and yeah, it went to 180 days. I can't believe it went to 180 days, but look at that. That's crazy, 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 crazy. Okay, okay, go ahead.
I have a question. I was just wondering what kind of diet would you recommend? A meat-based diet or a plant-vegetarian-based diet? Based on what you were saying about phosphorus.
Okay, well, I think every person should be individualized to what your preferences are, but also to what your disease state is, okay? And that's hard to do. It really is hard to do because, you know, you don't meet with your doctor for very long, and, you know, if you have access to a nutritionist, yes or no. But things should be individualized. I think there's a lot of merits to a vegan diet when it comes to a kidney patient because of that phosphorus issue, because of a few other issues too. You know, you just consume less sodium if you're vegan, if you're not doing any of the processed foods. The problem with that diet is, you know, it's hard to get the protein in there, you know. But you can do it. You can you know, you can construct a diet that's vegan that's going to be helpful for your kidneys. There are other diets out there that make a lot of sense conceptually for me. but they're very difficult to do. And I've I've talked it through to my patients, and I have yet to have, so there's these cardiovascular diets to prevent or eliminate the previous heart disease that people have, reverse heart disease. There's a lot of other diets, and some of them are based on veganism. Some of them are like paleo diets, so you have proteins. They're heavy on proteins, but they're low on. But I think the common thread between most of the very good diets are they eliminate a lot of the processed foods. They eliminate a lot of the sugars. The only source of sugar that you should get in your body is the way that God gave it to you, as a plant in its like original form, So apples have sugar, but apples have a lot of fiber in it too. And you need that fiber to help reduce the glycemic spike that you get when you eat something. These sugar drinks, like Powerade or even juices, they really cause you to spike up the sugar levels in your blood and cause problems. Okay, so next up I want to talk briefly about supplements. In the handout you got, there's going to be a long list. I'm not going to go over all these individually. The basic concept when it comes to supplements is, and medicinal herbs and Ayurvedics or Eastern medicines, is there's a lot that we don't know, basically. So maybe something is good for you, maybe it's not. It's hard for me to tell without the rigors of a truly scientific test. My major issue when it comes to supplements and medicinal herbs is that they're not regulated. The FDA, there was a law that was passed by Congress in 1994 that deregulated the industry. So if you are a producer of supplements or medicinal herbs, there's no oversight, and there's been a lot of abuse, documented abuse. If you read Consumer Reports, or if you look at certain busts of medicinal herbal industries, you will have contamination with like heavy metals, lead, arsenic, cadmium, which are all very dangerous for the kidneys. Remember, the kidneys are filtering all this blood, so these problems are potentiated when you take things like that. Also, when you have kidney disease, some of these herbs will interact with the medications that you need, especially if you're a transplant patient. There's a lot of things that you want to avoid, and so I have a list of some of those, and they can also have other medicinal effects that you don't want. So some of them act as diuretics. Some of them act as, some of them contain potassium in it. I had a patient 2 weeks ago whose potassium was to the danger point, needing dialysis, and I found out that he's taking a lot of turmeric. And turmeric is bound to potassium as a supplement. So some of these things can be helpful, or based on the opinion that you have. You just have to be careful. You have to educate yourself. And run it by your physician. There was a study that showed that more than half of patients do not tell their doctors what medicinal herbs or supplements that they're taking because they're afraid of what the doctor will think of it. So please share it with your physician so that we can give you advice based on the literature and what it can or cannot do to your kidneys. Educate yourself. What are the important kidney numbers to know? Creatinine is very important. Creatinine is a substance that we all produce. It is secreted by your muscles, enters your bloodstream. It's only removed by your body in your kidneys. So, back 20 years ago, that was primarily the way that we told our patients, hey, your creatinine is 1, your creatinine is 2. But it's not an easy thing to really conceptualize. It's not a linear relationship, meaning if your creatinine is 1 and it jumps from 1 to 2, that means something different than if it's 2 and it goes to 3, okay? So these are very different intervals. So what we have is an equation called the eGFR, the glomerular filtration rate. Some people call it kidney percent. It's not technically a percent, but it's an easy way to kind of conceptualize it. The GFR is a linear response. So if your GFR was 80 a year ago and 60 right now, then if the disease progresses at the same rate, it'll be 40 in a year, 20 in another year, and then dialysis. So it's easier for you to kind of follow your kidney progress if you know what your GFR is. Other numbers that are important are potassium, obviously. There's certain levels of potassium that are high, but you can tolerate. But once you cross that 6 number, then us kidney specialists, we get really nervous. We think about sending you to the emergency room. We give you medicines to make you feel sick to get rid of that potassium. But it's not important. It's not as important in some individual patients, and that's why we need to individualize your diet. Bicarbonate and carbon dioxide. So basically, the kidney is the source of acid removal from your body. Okay, so when your kidneys are not working 100%, acid can accumulate within your bloodstream. That can cause your bones to be weak. It can cause you to lose muscle mass. It can cause your kidneys to fail quicker. So we keep a close eye on that, but I know that there's a lot of stuff on the internet talking about alkalinizing your body, taking sodium bicarbonate. And I had one patient who was reading all that stuff on the internet and got his bicarbonate level high to dangerous levels. So you really want to be monitored when you do it. I prescribe baking soda, but I tell my patients you can take the baking soda, or you can take a pill that just has baking soda in it. That's sodium bicarbonate. That neutralizes the acid, but you have to have your blood checked. You have to have your blood levels checked. You have to know if you're in that safe range. If it's too high, then you're going to cause cardiovascular problems. You're going to have a heart attack, stroke, those types of things.
I have a question real quick. Ginger. I was confused about the ginger. Is that okay to take?
Ginger?
Uh-huh.
Let's see here. I think it's on here.
Yeah, you just passed it.
Yeah.
Oh. Because you
So-
said it would interfere with the medication, the diuretics, herbs, and then one was ginger.
Yeah.
What are you saying?
So I don't know the specific medication that ginger does. This is taken directly from the National Kidney Foundation website. So I'm not certain.
If you take those, see there it is. You don't want to take those because it might interfere with.
Yeah, but remember,
not ginger.
so these just interact with other medications. This doesn't tell me. I don't know what medicines you are on in particular, and I don't know. So it's hard to tell. So these have to be individualized based on what you're taking. But when it comes to ginger specifically, I don't know the interaction that it has. I will look it up for you and I will tell you. Okay?
Dr. Gilani,
Yes.
you said something about alcohol.
Yeah, alkalinization, I think is what it is.
Okay.
There's a lot of stuff on the
Does that
internet about it.
involve, alkaline water?
Not beyond that too. So there's a concept of that. I've had a couple of patients bring that up to me. I haven't seen anything in the medical literature that says that helps. And when I know the physiology behind it, it doesn't really make that much sense to me. But I'm just one physician when it comes to that. But we do alkalinize you if you need it. A lot of patients have been on sodium bicarbonate that's prescribed by their physicians. We just check your blood levels to know when you need it. That's when we prescribe it, and it does have a protective effect. But it does have a harmful effect if you overshoot it. Urea is also very important, especially for the people right before needing dialysis or transplant, or the people that are on dialysis. So what is urea? Urea is a major component of urine. That's where the name urine comes from. Urea is the byproduct of protein breakdown, okay? So if you're eating too much protein, you will produce a lot more urea, and it's uremic toxins. So for the patients that are close to needing to start dialysis, if you consume less protein, you produce less urea, and conceptually, you can buy yourself some more time when you're at that level. But those are patients that are, if you're doing too much. So if you do too little protein, then you're not building muscle, okay? So there's a sweet spot when it comes to protein. If you do too much protein and your uremic toxins are too high, you will actually break down muscle because you produce inflammation, a catabolic state. Okay?
Can I ask a question in relation to protein?
Okay.
I was hoping that you could so that I could better understand the relationship between protein and the kidney. The thing that confuses me a little bit is the daily, if I'm a healthy adult, is 56 grams of protein, and you were suggesting 1.5. So those numbers are numbers, but I was trying to figure out what's the relationship to actual the protein to the kidney, what's happening.
Okay, so so a couple of things. One is the urea, like I just explained. So if you're consuming a lot of urea in a very decreased kidney, if you're consuming a lot of protein in a very decreased kidney function state, then you have more urea just in your body. It doesn't get eliminated by your kidneys; it accumulates. Causes a lot of things. Causes you to feel sick. Causes you nausea, decreased appetite, all these things. So that's one avenue for it. Another avenue is on a much smaller level. Do you remember how I described how the ACE inhibitors work? They decrease the blood pressure within the filters themselves. A decreased protein diet also does that. So you're actually decreasing the pressure, the amount of work that those millions of filters have to do, the amount of pressure put on the walls of those filters as well. And so that helps in reducing the amount of protein spilling into your urine, but it also helps having your kidneys last longer. It helps them along this, and it kind of is the same kind of mimicked effect. You can recreate that effect with the ACE inhibitors too.
So if I understand it correctly, too much protein won't be able to be filtered by the kidneys, and your body will be filled with a toxin. The other part of it is it puts a lot of stress or pressure on the filters, which could, I guess, collapse or stop working.
Yeah. You want to reduce the pressure in those to keep the kidneys working longer, and also to reduce the amount of protein that spills into the urine.
So could you just give a quick definition of the filter? Is that like an artery, or I'm not quite sure what it is?
So it is it's like a capillary tuft, okay? So really, really tiny. And a lot of the diabetics in here that have diabetic eye problems, these capillaries are about the same size as the ones in your retina. Okay, so if you're having problems with your eyes and you presume that you're having the same problems with these tiny little capillaries, you have about a million, 1 to 2 million in each kidney. But it's a tuft. It looks like a ball when you look at it under a super microscope, and then you have an open space that they filtered through, and that's where the urine is. That's the first stage of urine production. And some stuff is supposed to go through, and some stuff is supposed to stay in the blood. And protein is supposed to stay in the blood. And if you have a disruption of that membrane right there, then it leaks through and causes problems.
Thank you.
This is a quick question.
Yes.
What is a protein supplement? They said if you need to decrease your protein, but yet you need a little bit more, then you would take a protein supplement instead of eating the most protein. You heard about that?
So yeah, and this is the issue with talking about a kidney diet. It's hard. It's hard to talk about. It's hard to implement it, right? So
What is a protein supplement? Is it capsule? Is it powder? Is it
Shakes and bars.
yeah, so protein supplements, right? You can have them in shakes. You can have them in like syrups. Claire's going to talk about that and address that at length. But basically, for people that aren't getting enough protein, we have to supplement it in their diet. For people that are getting too much protein, we have to convince them to eat less. Moving forward. Oh, sorry. Go ahead.
Most people, well, not most, a lot of people no longer urinate when they're on dialysis or when their kidneys have made it to stage 5. And in my case, I now urinate 4 times a day. But I was told by my nurse, though I pee like a normal person, the stuff that's coming out isn't toxic. I'm thinking if I go in the morning and at night and every time you're supposed to go, why isn't it? So my kidney's still the same.
Yeah.
But how come I'm peeing so much and the toxins like the urea, that one, isn't coming out? What's coming out?
So the best way to answer that question is you have to think of urine kind of like as an engineer would think of it. Okay, so urine has 2 components. One is the toxins that it's trying to remove from your body. The other is volume, fluid. Okay, so we think of, sometimes we call a dialysis machine a kidney, and those are the 2 components of it. How much are we going to clean? How much clearance there is? and how much fluid we're removing, okay? So if you're still making urine, and it's commonplace, a lot of dialysis patients still make urine, but we know that it's just not clean. The toxins are still in your body, and the mechanism of which is mostly on those filter levels. There's just not enough filtering that's happening.
So the toxins are only coming out with the washing of the blood.
Exactly. Okay, so moving forward, so there are 5 stages of kidney disease. Based on what your GFR is, stage 1 is the most minimal amount of kidney disease. Stage 5 is when you're pre-dialysis. The cutoffs are based on the GFR. Most people don't even realize they have kidney disease. This is from a survey done. So when you have stage 3, that's CKD stage 3, GFR is between 30 and 60. Only 5 to 11% of people really knew that they had anything wrong with their kidneys at all. That's a failure, I think, on the physician's standpoint, not explaining to you what that means. It's a mild level of kidney disease, but it's present and you should be aware of it because there's preventive measures that you can take, and you should use that. But what's more alarming is for the people that have stage 4 kidney disease, kind of the pre-dialysis kidney disease, 40%. I don't have a good explanation for that other than, some people don't have access to care, some people don't get their blood checked regularly. The only way you can tell if you have that form of, if you have kidney disease is by checking your blood. So there's, for me, I don't really understand it, but I know it's a problem. And I think we should, take home that message that, we should just be aware of what we have. Moving forward, most people don't die of kidney failure. Most people have cardiovascular events. Okay, so most people that are diagnosed with kidney disease, they don't end up on dialysis. They don't end up needing transplant. Most of them, either for a good reason or a bad reason, never need dialysis, and it's because you just increase your risk for heart attack and stroke once you are diagnosed with kidney disease. So, hand in hand, being told you have kidney problems, you should be trying to think of ways to reduce your cardiovascular risk. So, cholesterol, diabetes, obesity, and for me, most importantly, smoking. You have to quit smoking. Smoking will not only cause your kidneys to fail faster, but the risk is compounded, okay? So what does that mean? So like if you just have individual risk factors, if you just have one risk factor of being overweight or smoking or whatever, then your risk is pretty low for a heart attack or stroke. But if you have multiple risk factors, smoking plus overweight, cholesterol, all these things, you increase your risk by 14 to 20 times, and you add kidney disease to it, it increases it even further. So you have to take control of what you can. Smoking is one of those things that you do have control over. I mean, some people don't feel that they do, but we want you to feel like you have control over, and we want you to really, really stop smoking.
Doctor, what percentage, if you stop smoking, can you look at? You said 40% increase.
Mm-hmm.
So say if I quit, because it's a stress relief. You're telling me that if I quit smoking, that it's going to, give me longevity, longer life.
Yes.
But in essence, I've been smoking for 25, 30 years. If it's going to kill me, like kidney disease is going to kill me. I mean, why would I want to give that up? To be around a little longer? Well, I'm just saying, Doctor, you said 14%.
14 times.
14 times
Yeah.
is increased from smoking. Smoking for me is a stress release. I sit at home and I'm wondering when it's going to kill me. Well, if the cigarette's going to kill me, I would prefer to go out doing something I prefer doing. That's how I see it.
We live in a free country. You can do whatever you want, all right? We live in a free country. I'm not going to impose anything on you that I cannot force you to quit smoking, but smoking is a killer. It is a killer. We know it's a killer. It is the biggest health problem of the past 100 years, probably. And it's something that, when I have patients that quit smoking, the vast majority of them, when they quit smoking, is after they have a major coronary or something dramatic happens to them in their life. That's finally what it takes to have them quit smoking. But you can prevent that major coronary. You can prevent that if you quit smoking beforehand. So you know, just and you know, for people that when you're trying to convince someone to change something about their lifestyle, it is very hard to do as a physician. You have to acknowledge that some people are in different stages of where they are when it comes to that. And first and foremost, no one's going to quit smoking if they don't think smoking is a problem. That's just not going to happen, and I can't convince you of it. So I will try to convince you that smoking is a problem first before I try to implement a plan of how to quit smoking. But if you do feel that smoking is a problem, there are things that can help. There are new medications out there that can help. There are new strategies that can help. And you talk to your doctor about it. But it is one of the biggest things that you can change about what you're doing in your life to prevent a heart attack, to prevent a stroke, to prevent your kidneys from failing faster.
Well, I asked my neurologist, what would kill me? What is my life expectancy since I've been diagnosed and I've been on PD for 5 years? He said, like you just said, oh, that's not going to kill you, Jim. You'll probably die of a heart attack. Now, for my doctor to tell me that, you know, the stress factor of what causes a heart attack. You say, you know, some of these life things that I do, like smoke cigarettes, I don't drink. I stopped doing hard drugs a long time ago. The thing is that my concern is as I sit home stressing out how long I got, you know, am I doing this? Because I've been doing it for about 5 or 6 years, pretty much by myself. My neurologist just provides the medications that I need for my diabetes and my high blood pressure. Other than that, the treatment that I perform is done solely by myself.
And I commend you for doing that. That's great.
Well, I prefer to do that than to do the hemo and put it in someone else's hand. If I'm going to die or don't want to do this, I'm going to do it my way. Like you said, it's a free will.
Yeah, you know, and when it comes...
Can I just interrupt? I know that there's a lot, this is great having a dialogue, but in the interest of time, and to try to move along since we have the second half of the program, we do have, we're going to have a reduced Q&A time with Dr. Gilani, but I think you're also going to be around later after the event when we have a social hour, when we have individual conversations. So just in the interest of time so that we can finish the presentation and for our nutritionist presentation, I recommend that we hold the questions until later. So thank you.
Yeah. Just one comment is, yes, stress can contribute to heart disease, but smoking definitely has a higher contribution to that. So, so we'll talk afterwards, okay? When to start dialysis, when to be referred to kidney transplant. These are also important things that you should be aware of. So when does a nephrologist decide it's time to start you on dialysis? Well, the criteria really are you should have a GFR of below 15, and you should have symptoms of uremia or certain metabolic parameters that cannot be treated with medicine. So what does that mean? Well, you have to have a certain minimum amount of kidney function, and you have to kind of feel sick from the kidney disease. You know, the kidneys, they're a remarkable organ in the sense that you can live and not even notice you have kidney disease, and they're working at 10% of what their true function is. But eventually, you know, you'll start having these symptoms, and I'll go through them. And when you do, you don't want to downplay those symptoms. You don't want to, you know, pretend you don't have them, because if you do, you're really going to be hurting yourself. So you should be aware of what they are, and you should start dialysis in a timely manner. So the symptoms. So these are the symptoms. Try to memorize these because they're very important to know. Actually, no. So we doctors have a phrase for what this means. This is very non-specific. Okay. So what that means is these are symptoms that can show up in kidney failure, but they can show up in any million other diseases that you have as well. So you got to be honest with your physician when you're a pre-dialysis patient, so we can kind of tease out: is this decreased appetite from your kidney failure, or is it from the diabetes having effect on the nerves in your stomach? It's hard to tell sometimes, but you use these symptoms in conjunction with the laboratories that you have to kind of decide, well, when do we need to do this and how do we do it safely? The most important symptoms to pay attention to are decreased appetite, losing muscle mass, feeling kind of weaker, food can start tasting kind of funny, like metal. These are the things that you want to pay attention to. When it comes to starting dialysis, it's important that you've talked to your physician before so you can kind of have an idea of, well, what kind of dialysis suits my needs and who I am as a person. There's dialysis that you can do at home. There's dialysis that you do in a dialysis clinic. There's also, you want to do an early referral for transplant and hope you never are on dialysis. So I'm going to just briefly go over those different things. So peritoneal dialysis, I refer to it as belly dialysis. Basically, put a catheter in the belly, you have fluid in the belly cavity, and that creates a filter that removes the toxins and excess fluid from your body. So that filter is your gut membranes, okay? And it's not as efficient as being on a hemodialysis machine, but you do it for much longer than you would be on a hemodialysis machine. And so you get the same adequate amount of cleaning. The benefits of this are huge in that you can do it at home. You don't have to go to a dialysis unit. You can do it at home, and most people can do it on their own. I have patients that they can't even read English and they do it. It's not terribly complicated, but it's something that most people can do. The next thing is hemodialysis. So about 85% of the U.S. population is on hemodialysis in a dialysis center. Basically, blood leaves the system, goes through a filter. We remove toxins and fluid, and then the blood enters the body again. We can do a lot of manipulations with this, and you can do this at home too, but it's a little bit more work. We've all been in this situation, having to complete the entire dialysis session, but having other things that you want to do, and that's why I think home dialysis is a really good option for most people, either peritoneal or home hemodialysis, because you get a little bit more flexibility in what you do. But also you get, when you're doing dialysis at home, and in particular with hemodialysis at home, you're doing it a little bit more frequently, and you're improving your risk profile. So this is a very important curve. It's hard to interpret, but it's important for all dialysis patients to understand. So basically what this says is, how quickly I am removing fluid from you during dialysis has an effect on your heart, okay? So if you're an average size person, 70 kilograms, and you're on, a typical 3-hour dialysis run, if we're taking 2.1 liters off during that dialysis session, then you're here on this curve. So if we're taking about 3 or 3.2 liters of dialysis, liters of fluid on dialysis, then you're here on this curve. And this is a very important curve because this has to do with heart attacks. So the more fluid we have to take off during a dialysis session, the more risk it has on your heart. So that's why it's very important to limit the fluid you have between dialysis sessions. And this is a 50% increase. So it's very important to limit the amount of fluid that you have between dialysis sessions, or do more frequent dialysis sessions like at home when you do it 5 days a week. Okay? Some really smart doctor once realized that the week has 7 days and not 6 days, and we do dialysis 3 of those days. So there's a longer interval between dialysis, and so people that do dialysis 3 days a week, you are 3 times more risk if you're Monday, Wednesday, Friday, you're 3 times more risk of having a major heart issue on Sundays than you are on Mondays. And if you're a Tuesday, Thursday, Saturday patient, then that's Mondays instead of Tuesdays. And the reason is, the longer the gaps between dialysis session, the more risks you have. So a lot of us, what we're trying to do is minimize those gaps between a dialysis session. And one of those ways is by doing it at home and doing it more frequently. So someone took this data and just estimated that over a 10-year period, 100,000 people died because the week is 7 days and not 6 days. So it's actually a big deal. We don't think about it that much, but it is a big deal. And those weekends that you have, that's when you have to get extra vigilant about what you're eating and what you're drinking. Dialysis at home, daily hemodialysis, it's actually almost as good as getting a kidney transplant when it comes to how long you're going to live. So I'm a huge proponent of daily hemodialysis from that standpoint, especially if you don't have a kidney transplant, especially if you have heart disease underneath it all. I think it's really a great way to kind of and mimic that effect. And people that do it actually feel much better. So the people that have been on dialysis, that do it 3 days a week, there's that period when you get home, you're tired and it takes you time to recover. We call it recovery time. On average, that's 9 to 18 hours for a traditional 3-day-a-week dialysis patient. But if you're doing it at home every day, or 5 or 6 days a week, that's cut down to 2 hours. So even though you're on a machine for more hours, you're on a machine for more hours a week than you are if you're just going to a dialysis unit. You have more time to be yourself because you're not recovering all the time. And if you ask a doctor or a nurse, hey, if your kidneys failed, what kind of dialysis would you do? The overwhelming majority would do it at home. 50% of doctors say they would do it hemodialysis at home, and 43% of doctors say they would do peritoneal dialysis at home. The problem is 90% of patients are doing the opposite. So if it's good enough for us, why isn't it good enough for you? I don't know. But that's why I am a huge proponent of that. Kidney transplant, if you're in that phase of kidney disease, we want you to get a transplant before you ever even need dialysis. We never want you on dialysis. But that's hard to do because there are just not enough donors out there. Or you may have some heart disease, or you may have some other disease that prevents you from getting it. But ideally, once you're diagnosed with kidney disease, reach out there. You'd be surprised. I had a patient back in Atlanta. He was 21 years old. Kidneys shut down just all of a sudden right the week he graduated from college. He was in the hospital for 2 weeks being treated for this autoimmune kidney disease that he had. He was a really great kid. One of the nurses on the floor gave him her kidney. So you would be surprised at who'd be willing to do that. So don't hide the fact that you have kidney disease. Don't hide it from coworkers. Maybe you need to, I don't know, but don't hide it because you would be very surprised. And the important thing is, don't feel any guilt associated with taking a kidney from somebody else, because the studies show that if you can pass through the screening process to be a donor, then there's really no harm to you. Your kidneys will last just as long as anyone else. That other kidney will compensate. So please be out in the community, educating people about that. The people that get kidney transplants before starting dialysis, those transplants last longer than people that get kidney transplants after starting dialysis. So that's a very important distinction. And kidneys given from a living donor last longer than kidneys that are given for someone that's a deceased donor. And yeah, the earlier that you receive a kidney transplant, the better. The longer that kidney is going to last. I'm going to end this talk. This is a very difficult thing to talk about, and I'm open to suggestions from the audience. The majority of my patients, when they're diagnosed with kidney disease, they kind of go through these stages of grief. And some people get stopped here at the denial phase, refusal, and they don't progress. Or when they do progress through the stages of grief, they go slower than their kidney disease is going, If you're stuck in denial, your kidney disease isn't going to stop and wait for you to accept the fact that you have kidney disease. It's going to keep going. And if you're stuck in denial, then you're going to be shooting yourself in the foot, preventing yourself from extending your time without needing dialysis, or preventing you from getting a transplant early on. I've talked to a lot of patients about this, and especially the patients that have trouble with it, or have had trouble with this. And I think one of the common threads is refusal to accept support from the important people in their lives. So, I have patients that have known that they have kidney disease for years, and then all of a sudden they finally bring someone in with them to an appointment, and they had no idea. Don't go through this alone. Use the support that you have here through this organization. Use support from your family. Bring people to your appointments so that they can help you go through this. You're not alone. It's okay to be afraid. It really is. But the sooner that you accept the fact that you're afraid and work with it, the sooner you can do steps to help you with your health. And there is hope. Most people that have kidney disease, they don't ever end up on dialysis. There are new, just as Dr. Dirk said the last talk here in Oakland, there are new advances in the pipeline. There's an artificial kidney that should be hopefully within the next 3 or 4 years, maybe even sooner than that. There's other things, 3D modeled scaffolding produced in stem cell assisted organ development. Really crazy things are coming out in the near future. So there is hope. Many people that are on dialysis, they live very active lives. Home dialysis modalities are underutilized. Try to utilize the best that medicine has to offer for you. And transplants we're very fortunate that we live right next to 4 major transplant centers. The busiest one in the country is here too. So there's a lot of transplanting that happens. Get plugged in, go through the process, and there is hope. You can live a very long and fruitful and productive life. All right, thank you very much. I really appreciate it.